you will find some slides are there will be overlapping even in my presentation. I still do because when you make it a consolidated one, and according to you have to customize and see it here. This is one of the most important cause of unilateral visual loss worldwide, especially in young people. Road traffic accidents and industrial occupational injuries are the most common affair, domestic also. These are the data, the exact details are not available. 2.5 million eye injuries in US per year. Of these, 73% are male, and global, exact global and Indian data are not available. In general, IOPD, 10% to 27% of all eye patients may have the injuries, maybe from a small foreign body to the larger. It looks little larger figure, but if you go through by this, it is there. And in ocular emergencies, other than glaucoma and CRA, probably this is the topmost of the any eye injury comes to as an emergency. And of all injuries, 90% are preventable. This is very, very important. Management is more difficult rather than it is easy to prevent it. And the safety measures in the domestic, occupational, environmental, road traffic, schools, and other service-related military duties, etc., the preventable aspects are very, very important. Dr. Vineet has talked about the glaucoma. So these are the 7 rings of the anterior segment trauma where the tissues or the structures are involved, whether it is the iris sphincter tear, iridodylisis, angle recession, microdialysis, trabecular meshwork tear, gonadal dialysis, and traumatic cataract. So these are the things which you may see that affected, and immediate management requires probably whenever there is a traumatic cataract which or the exposed wound, rest all needs a long-term management. Assessment, as we have already discussed, I don't need not to go in detail. This is a NSV commando who had a grenade blast injury with left examination. These are the basic principles of examining any emergency case which is applicable to a small trauma to the major trauma or any other ocular patient. And detailed examination, if you can get it done visible on slit lamp, if there is a obscure like in the low, here is a traumatic cataract with corneal laceration, the posterior segment evaluation by the B scan, if it is possible, if the wound is not exposed, should be carried out. If it is exposed, then the CT should be done. MRI is debatable because the foreign body, you don't know the nature of the foreign body. So plain X-ray followed by the CT has to be carried out. Wherever you have access and possibilities, you can use any other investigative equipment. Assessment, the suspicion of scleral tear is most important. It looks very small limbal injury, and you see there is a subconjunctival hemorrhage, and later on you find that there is a extensive subconjunctival scleral tear is going on, the ciliary body is collapsed there. These are, we have seen those cases. And here is the gonioscopy, the delayed assessment of the glaucoma. As last talk there was on the angle recession glaucoma. All angle recession glaucoma do not require surgical intervention. In fact, initially the pressure rise is not because of angle recession. It is because of the hyphema and the entrapped hemolytic RBCs in the trabecular meshwork. So if you can give time to control the pressure medically, maybe for 3 months or 4 months, probably the most of the cases will not require surgery. That I have seen. Earlier, if any patient coming with the 50 pressure, not responding for 7 days, I used to go for the AGU. Then I realized that it is not required. Later on, some cases, pressure was 36, 40, and angle recession was almost 120. I did not operate it. He is a cricket player, and we managed it with the medication. Now it is 5 years, and he is without medication and absolutely fine. So proper assessment when to intervene surgically. About trabeculectomy, since it was already discussed, but if the angle recession is less than 90 degree, then trab pressure is not controlled, can go. Any angle recession 180 degree and above, probably the trab will not be functioning in addition to the conjunctival stresses and all those issues are there. There is in pediatric cases or in cases you may find there are the multiple injuries, polytrauma, not only the polyocular trauma, the polytrauma. So the detailed examination of the other part of the body is equally required, and in the trauma cases it is a joint effort, that you must remember. That particularly brain and mass injuries or root traffic injuries, etc. In some cases the patient in ICU and the eye examination is the last, first the life-saving systems are being taken care of. Why should you perform the stepwise management? This is the same patient of the RK injuries. Initially we did, it was the lens was prolapsed, iris was, so we had removed the lens and this corneal suture was put by me and removed the lens. Then the anterior vitrectomy was done and it was left aphakic. It was left aphakic, and after 6 months of the surgery, then the scleral fixated IOL was performed in this case. So the stepwise management is always beneficial. Eye is inflamed, post-operative inflammation can be devastating in the major surgery. Fresh bleeding can also detail. Corneal lacerations and edema can limit the visualization. Integrity of globe is lost structure, not in their usual anatomical place. Once integrity is restored, carry out better assessment and do the secondary procedure. So these are the different stepwise management. Repair corneal and scleral lacerations, remove blood in AC, aspirate ruptured lens, iris effusion, reposition. Then the next stage comes the cataract surgery. If there is not possible to do in the past, so you have to weigh every case. In which case you will go with linear small corneal tear. With traumatic cataract, you will do the repair of the corneal tear and take up the cataract also. And when you are dealing with the cataract, traumatic cataract, it looks very simple before surgery. But during surgery, it is a Pandora box. You don't know what is behind it. So be prepared for the posterior segment surgery to take over, because there may be the rupture of the posterior capsule, linear rupture, or which has during the procedure it has created. In young patients, it's a cortical matter, it is aspiration possible. With the elderly patient has injury, probably the lens when you are handling may go into the vitreous. So dealing with the traumatic cataract, a word about the CTR used in the cataract cases and other. I personally feel that if the zonulysis is more than 120 degree, and particularly if it is engaging the inferotemporal quadrant, it is better not to attempt any CTR, etc. and plan on the scleral fixated IOL, because in long run these all cases, those who have been given capsular support, after 5 years or 10 years, we have seen that some cases do develop the subluxation of the entire bag. Lens is not subluxated, the bag itself is subluxated. So you have to decide in which case you will go with the CTR, in which case it is the preferred choice is the scleral fixated as a primary sitting or as a secondary sitting. This talk is, I think, 11 minutes.
So right.
Yeah. So stepwise management is very, very important. This is angle recession having the tube post-op. This is a post-keratoplasty. This keratoplasty I did it under the guidance of Professor Gupta in SMC way back in 2002. These are traumatic cataract. Here you see iridodialysis, and here repair of the iris. It had a glaucoma also. So I put a plate, I did the repair, I removed the cataract, but when I was removing cataract, I found the posterior capsule integrity was totally disturbed. The lens had gone inside, and the VR surgeon took over, and then we removed the lens, and in the second sitting, the scleral fixated IOL was taken in this case. So challenging managing traumatic cataract, I have already mentioned. These are pre-operative challenge is the calculation of IOL class, and here since the traumatized eye, so you have no option except to assume with the available data that the both eye had a same kind of a refraction. There was not a anisometropia. In some cases it happens. So you must ask that don't go with the simple, the IOL power of the other eye is coming same, so you put a lens also same power of the lens in baseline. Because there is a good number of cases I have seen, those in the one eye is having high myopia, other is normal and vice versa. little bit history teaching about this, and that assuming if it is more or less same, then we go with the presumed IOL part. If there is a corneal injury, astigmatism, you are expecting corneal transplant to be carried out in future. So it is then in those cases it is better to do the repair, remove the lens, not to put the IOL, and once it is healed, then you plan as a the secondary IOL and corneal transplant in a same single sitting. So then probably you will get a better presumed IOL part. This is a small, not a professional player, but this is a shuttlecock injury, and it clearly shows what do you get after removing it, because the anterior capsule is ruptured. He was I think he is now 28 years or so in injury. He was 24 years. Since this tear is away from the optical zone, I expected a good visual outcome. Around -1 cylinder, he is having 6-9 vision. Some nebular opacities are engaging in the central part. Worrying not. So compartmentalization of injuries is not possible. You have to evaluate any case as a total eye examination and management. Few more seconds, not a few. Now see what happens once you start removing, aspirating, since you are a young traumatic cataract, early patient. And when I removed, I could see there is a linear posterior capsular tear. I could assess it. So removing subsequent matter you have to be very careful. But luckily there was no vitreous disturbance in this case. You can see the linear risk. So obviously in this case I don't like to put a CTR ring also. It is because ultimately the long-term results are very, very important. So 3-piece IOL was used in this case. It would have been large or the vitreous would have been coming, then I would have not gone with a 3-piece IOL in the sulcus, but would have preferred to go for the scleral fixated IOL. Because you are doing the management for whole life of the patient. Young patient 25, you are not happy that to present in conference that it was a more than 180 degree of zonulysis and I put the CTR large tear and I put the lens multifocal. No. See what is going to happen after 5 years. Thank you very much.
Thank you, sir, for an excellent talk, an excellent